Good morning, everyone. Welcome back to the UBC Learning Circle. I'm pleased to be joined in circle today by Drs. Nel Wieman and Terri Aldred. Today, we're all going to be discussing the COVID-19 vaccines. We know that this is a topic on many people's minds right now, so please feel free to put your questions in the chat box and we'll get to it as soon as we can. So before I get into anything else, I would like to acknowledge that I'm zooming in from the traditional, ancestral, unceded and occupied territories of the Hunkaminam-speaking Musqueam people. I would also like to acknowledge the First Nations Health Authority for generously funding the UBC Learning Circle and allowing us to have the conversations we do. So gentle reminder here, the topics we cover can sometimes be sensitive or emotionally triggering. In particular, we recognize that the ongoing pandemic is an emotionally salient topic for many of us. So please make sure that you're looking after yourself. If at any point you feel that you need to talk to a friend, elder, counselor, or family member, please don't hesitate to do so. So last little bit out of me here is introductions. My name is Cole. I'm from the Tsawwassen First Nation. I'll be facilitating the session today. Sharing our digital space, but off camera are Cynthia, our production coordinator, and Winona, our program assistant. If you feel so inclined, please introduce yourself in the chat box and we'll get started. So with that, I'd like to pass the mic on over to our guests.
Thank you, Cole, and Ani Boujou to everyone that signed in so far. Hopefully more will join us. I'll just give a brief introduction of myself. So my name is Nel Wieman. I'm originally from Little Grand Rapids First Nation, which is a remote fly-in community in northeastern Manitoba. I spent most of my life living in Ontario. I'm trained as a psychiatrist and practiced clinically there for over 20 years, including 8 years working on reserve on the Six Nations of the Grand River Territory. About 3 years ago, I moved to Vancouver to work for First Nations Health Authority and sort of made the switch into public health just in time for a global pandemic to happen. So it's been a very busy last year and very stressful and difficult for all of us. And I just want to actually take a moment just to acknowledge the people, the First Nations people that we have lost over the last year and send my condolences and my sympathies for that. I will begin, I should mention, because I work at First Nations Health Authority, my current job title is Acting Deputy Chief Medical Officer. And I'm also the president of the Indigenous Physicians Association of Canada. So enough about me. I'd like to move forward to the land acknowledgement and center myself. So someone could advance the slide. I don't know if it has. Has it? There we go.
There we go.
Okay, next slide. So it's always important for myself and others whenever we do presentations to explicitly center ourselves and place ourselves where we are at. So I'm Indigenous, not on my ancestral territory, and I respectfully acknowledge the land on which I work, live, and play is the traditional, ancestral, and continually occupied territory of the Coast Salish peoples, the Musqueam, the Squamish, and the Tsleil-Waututh nations. And I'd also just like to quickly thank the Cole and the organizers of this learning circle that have brought me and Dr. Aldred here to spend some time with you this morning. So that being said, I'll hand over to Dr. Terri to give her introduction as well.
Thank you. Actually, and we can move the slide ahead. I had an introductory slide, but I'm also happy to just speak to it. So my name is Terri Aldred. I'm Deketh from Clasden, a member of Lasiliu, the Frog Clan, traditionally known as the Voice of the People. On my mom's side and on my dad's side, I'm mixed European and Métis Cree. I'm a family doc by trade, and I've worked with Terris County Family Services for the last 7 years, doing both outreach and following up with virtual care to 12 First Nations in North Central BC. I recently joined FNHA as well as the medical director for primary care. And yeah, I do a few other things, but I'll stop there. This is a picture of me and my maternal grandmother. I just like to bring my family and my community with me on my journeys as much as I can. This picture is of Lheidli T'enneh traditional territory where I have the honor to live, work, and play. Just to the right of the picture is where Lheidli gets its name, where the two rivers meet, so where the Nechako meets the Fraser River in fall. So beautiful traditional territories that we're calling in from. If we could try move the slide. I guess just a rough overview. So I'm just going to talk a little bit initially about the vaccines in general and offer a little bit of background of where we are currently, and then discuss a bit about some of the virtual services that have been stood up at FNHA to help support community members during this time. And then discuss a little bit about my own vaccine story before I hand it back to Nel to discuss kind of the vaccine rollout approach and all her good work that she's doing in public health. Anything you want to add before I get started now? No? Okay. Okay, so right now we have two vaccines that are approved by Health Canada in Canada, and that's the Pfizer and Moderna vaccines. Both of these vaccines are what we call mRNA vaccines. And so these vaccines, although novel, have been around, like the type of vaccine mRNA have been around for actually about 20 years and have been used in small scale outbreaks previously. And so I know there's some misinformation around that they're completely new, but the technology have been used before. And essentially what this type of vaccine does is it helps to target both parts of our immune system. So both our humoral and our cell immune systems. And I won't quiz anybody on that, but essentially it helps to develop both an antibody response as well as cellular memory. These vaccines have been, so in the course of the last year, these vaccines have been thoroughly tested and have gone through the regular safety trials that all vaccines are needed, including ensuring that they fall and that they address all the requirements to be approved by Health Canada. And so the reason why we were able to produce these vaccines so quickly is not because the steps to assure safety were cut. It was because scientists, the academic community, governments, and companies, private companies, were all working together with the same goal to help kind of counteract the devastation of the COVID-19 pandemic. And so a lot of the bureaucracy was cut down and people were sharing information and working together to produce these vaccines. And in addition, many vaccines, when they're first produced, when they go to their human trials, initially they don't actually have a large number of volunteers, so it could be in the hundreds to the low thousands. But due to again the global effects of COVID and the the massive impact it's had, they actually had 30 to 40,000 people in each of the initial trials for Pfizer and Moderna. So actually a lot more people were part of the early clinical trials than normal. And although we initially there were a lot of exclusion criteria in those studies, which is normal to do, over time they started having more people with various chronic diseases and at various stages of life be part of the clinical trial. And so there was a good representation. Although these trials weren't done in Canada, they were done mostly in the United States. They did have some First Nations communities, including the Navajo Nation, that had volunteered to be part of the trial. And so this background, all to say, is that these vaccines are safe and they're very highly effective. For both of them, even after 2 weeks after your first injection, it's around 90% effective, give or take a couple percentage points. And then after your second dose, it goes up to about 98% effective. So they're very effective against COVID. And although there is still some concerns around some of the long-term complications and for certain populations, like for those who are pregnant and breastfeeding, although I know those guidelines are changing rapidly as we get more and more data. Those long-term risks at this point are purely theoretical, and however, we know the effect of that COVID's having, including people dying of COVID, but also people having long-term sequelae of COVID. And so in BC, there's been 3 specialty clinics that have now been stood up to help people that are having the quote-unquote COVID long hauler or post-COVID syndrome, where people are actually having long-term symptoms like shortness of breath, fatigue, and including depression and anxiety, beyond 6 to 8 weeks after their initial infection. And so, so the vaccine really will help to counteract the morbidity and mortality of getting COVID. And so I guess just to touch for the side effects of the COVID vaccine, a lot of it are very typical for many vaccines, including you can have a sore arm, kind of general muscle aches, low-grade fevers, and the only absolute contraindication to getting the COVID vaccine is having an allergy to any of the components of the vaccine. However, when you get the vaccine, they will go through, any potential allergens, and those sites will also have anaphylaxis kits in case there's an unknown allergy. And the biggest thing, or the most important thing, is that once vaccines do become available for you, it's still really important to adhere to the public health measures. As we get more data, we'll be able to know more about the effect, but at this time, we still don't know if people who have been vaccinated can transmit the virus. And so, although the vaccine offers personal protection for you, it's really important that you still keep social distancing, not gathering, wearing masks, using hand sanitizer, so that you're ensuring that you're still protecting those around you who may not be vaccinated. You can move the slide, please. So for COVID-19 among First Nations in BC, this was updated on January 16th. So a bit out of date now, but shows the numbers in each of the health authorities. So in Fraser, there's been 498 cases, in Interior 394. In the north where I'm located, unfortunately, we've had over 1,000 cases, 714 in Vancouver Coastal and 349 on Vancouver Island. There's been just over 3,000 cases confirmed across BC. And at the time, there was about 953 active cases in BC. And I think 3,229 being tested. And so, so certainly I'm still seeing the effects of the second wave, where our case numbers were definitely increasing, and particularly in the north. We had a large increase in the second wave. We actually did quite well, in the first wave and through the summer. And so, definitely making a lot more real close to home. Anything you want to add now?
No, I'm good so far. Thanks, thanks, Terry.
Okay, thanks. We can move the slide. I keep on trying to move it myself. Thanks. So the number of cases, so we've in our near community, so like on reserve, was around 1,322 cases. And 550 of those were considered active. And then off reserve, there was 1,655 cases, 384 considered active. So slightly more in our urban and away from home populations. Next slide. And so just to touch on some of the services that FNHA has stood up since the pandemic started. On April 1st, the First Nations Virtual Doctor of the Day program began because due to many communities closing, including not having people leave, but also not having people come in, like physicians that do outreach like myself, or nurses and that sort of thing, there seems to be an urban need to ensure that people had access to physician services, including being able to get their prescriptions refilled, and to talk about different things that are happening in case they did need to leave on a more urgent basis, and different things like that. And so this service was stood up and as I said, on April 1st, and it's open 7 days a week from 8:30 to 4:30. It's available through Zoom or phone. Zoom, so that we have the ability to be able to do some assessment, is preferred, but we can also do phone visits, knowing that some people have connectivity issues. And so there's the number there, and it's manned. So there's 4 lines open every day based on which region you're calling in from. So on the island, North, Interior, or Fraser Coast Salish. And our docs are screened and vetted to are those who have established either good relationships locally and have a culturally safe and humble practice. And through that work, there was already seen to be a huge need and gap around mental health and addiction services. And so in August of 2020, we stood up the First Nations Virtual Substance Use and Psychiatry pathway. And so these pathways, so there's 2. So we have 1 line for addictions and 1 line for mental health. And we have 14 addictions docs and 7 psychiatrists who have worked with our services. The psychiatry is open from 10 till 3, 5 days a week, and substance use is from 9:30 to 5:30. Again, 5 days a week, Monday through Friday. And although the program still requires a bit of a referral, we try to improve access by having it to be any kind of health or wellness provider. So it could be a mental health clinician in community or a community health nurse that can also refer into the program. In addition, patients can also go through the First Nations Doctor of the Day program to get access to VSEPs. We can move the slide. Oh, and the programs are open to all BC First Nations and their families, including our urban and away from home population, so people who may be from elsewhere but are residing in BC. So I just wanted to share a bit about my own vaccine story. At this time, I'm now fully vaccinated. I had my first injection of the Pfizer vaccine on January 1st, which felt like a really great way to start the new year. And in the 2 weeks before I got the vaccine, I had kind of a lot of anxiety just around whether or not I was going to be eligible in the first round, because I had resumed doing outreach to First Nations communities. A lot of that anxiety came because I didn't want to be a vector. I didn't want to bring bring COVID into the communities, but also seeing not having that in-person connection was having, its own adverse effect on my patient's health. And so kind of balancing that. With the inclusion of rural and remote Indigenous communities and the providers that serve them in the first round, I was eligible and got an appointment. And once the appointment was made, the anxiety, I was really excited, but there was also some anxiety because there's been, in general, so much anxiety around COVID, so much things on social media around COVID and the vaccines. And so, there was, some of that came up in me too, being like, okay, so I'm going to go tomorrow to get this vaccine, and really kind of like needing to navigate that. And so for me, it's really important that I connect and ground in certain ways. And I do that by smudging and prayer and meditation or being outside. And so using that time to kind of get quiet, to get by the water, and to, help me to get to a place where I was going into the vaccine with a good heart and a good mind, where I believed in the power of the medicine and felt like I was doing the best thing, not just for me and my family, but also for the communities that I serve. And so the next day I went and got my vaccine, and I honestly, right after I got the vaccine, I was just flooded with relief. I was, I was tearful because it just felt like for the first time in like 8 months, there was a little bit of light at the end of the tunnel. And I could see that, relief was coming, and that we were going to be able to save, our elders and our community members from further grief and loss. And also hopefully be able to resume some of our services that have been lacking due to restrictions around COVID. And then I think just last Thursday, I got the second dose of the Pfizer vaccine. And I think lots of people have been talking about how when you get the second dose, you have a little bit more symptoms. And so after the first dose, I was a little tired, and the next day my arm was a bit sore, but I went skiing, and by the time I was done skiing, I didn't even notice. The second time I got the vaccine, I again was mostly the first day I was just tired, and the second day my arm was a bit sore and I had a little bit of muscle aches, but I took a little bit of ibuprofen, and by the time it wore off, my symptoms had resolved. And so, for me, my side effects were quite minimum. I was lucky that way. And, I just feel, I feel empowered. I feel, hopeful that we're, that we're turning a corner with this pandemic. And so, I just wanted to share a bit of my own journey with you all, and just encourage everyone, if you have questions about the COVID vaccine, please talk to a provider that you trust, look for sources that you trust, and ask lots of questions, and make sure that you get to a point where you feel comfortable and confident, and then also remember to help prepare your heart and your mind to receive the medicine in a good way, just like we would do with our traditional medicines. Snachalia, thank you. And I'll pass it to Nel.
Great. Thank you, Terri, for all of that. And so if we can just move to the next slide. And I did see the question in the chat, and I think Terri and I can try to answer that in this part of the presentation as well. So I just wanted to give people a bit of an update on sort of where we are now. Terri presented some data specific to January, but in British Columbia, for example, as of 2 days ago when I did these slides, on that particular day in the 24 hours preceding, BC as a province had 449 new cases. I believe yesterday was up a little bit to something like 559 cases, I think it was, provincially, making for a total of around 77,000 cases, a bit more. And unfortunately, as we've mentioned, in provincially 1,335 deaths, which I think there may have been one or two more. I can't remember off the top of my head, sorry. In British Columbia, among First Nations, we have had just under 5,000 cases total since the pandemic began, and around 80 deaths. And as I mentioned off the top of the presentation, we feel very much for communities who have lost community members, and our hearts go out to them. And it obviously is one of the major inspirations for, I think, both of us and all of the people working on the public health response to COVID-19, including the vaccine rollout. So these include cases in community and away from home. Now, you may have heard a little bit in the news. I don't want to go into too much detail about variants of the virus, and they're called variants of concern, or VOCs. But there have been different variants already identified in the province of British Columbia. So for example, B117 is the UK variant, or United Kingdom variant. B1351 is the South African variant. P1 is Brazil, and B1525 are Nigeria. And those are the first four that I have heard of. And in particular, in British Columbia, we have somewhere around 80, probably a little bit more cases of the variants identified to date. In January, for example, British Columbia was only testing around 15% of the samples, so it's easy to understand that these numbers of variants may be an underestimate. But now it was announced by Dr. Reka Gustafson, who was covering for Dr. Bonnie Henry, that British Columbia is now testing about 70% of the samples. And the reason why these are variants of concern are because there are issues around the variants, in some cases having ease of transmission, meaning the spread, and perhaps being causing more severe courses of illness. And there may be, these things are being researched all the time, which is why I'm sounding a little bit vague around whether or not the variants have any effect on the effectiveness of the vaccine. So there's a number of questions around these variants and why people in public health are keeping such a close eye on them. The picture to the right, I just wanted to make a note. This was from the provincial survey that was done actually last summer. So the numbers may have changed a little bit, but to just highlight for people that, COVID-19 has been creating challenges for everyone in British Columbia, including BC First Nations, on a number of different indicators. So for example, mental health, we've all talked about and felt it ourselves, sort of the stress of living in a pandemic where at times it's felt very uncertain, very unpredictable, and we've had very little control in some respects over, how this is going to go. And the fact that the vaccines are actually, as Dr. Terri mentioned, one glimmer of hope that, there's going to be a way out of this, at least living under these public health measures at some point in time once we get the majority of the population vaccinated. So next slide.
Sorry, Dr. Wieman, I just wanted to jump in here a little bit unsure of the language that's being used. When you use the term variant, what is that? I guess, what does that mean?
Sorry, those are variants of the virus. And specifically, it has to do with, Terri showed the picture with the little red spike proteins. And so when there's a significant difference in sort of the shape of that protein, that makes it a variant. So it's like a mutation. All viruses mutate. But when they sort of differ in a significant way, then they become variants. And that's why they're concerning, because like I said, there's a potential of spreading more easily. And so you've heard probably people talk in the news over the last couple of weeks or so that, we are kind of, not to sound alarmist, but, in a race, in a way, provincially, nationally, globally, to get enough people vaccinated before these variants can spread more widely.
Okay.
Okay.
Great. So the variant is so there's a virus and essentially they're just a little bit different shape or something, but it's the same virus. They just attach differently or infect
Yes.
differently or whatever.
Yes.
Okay.
So all viruses mutate. That's the nature of viruses. But in this case, people are keeping a close eye on how the virus mutates because of the potential implications for people's health, what it might look like if they get sick with the virus, and then how we go ahead treating or addressing the virus and stopping the transmission through vaccines.
Right.
So if I just look at this slide, this is, if you go to the BC provincial website, you will see the same graphic. This is essentially British Columbia's COVID immunization plan, of which First Nations fit into this. And there have been some changes over the last couple of days, actually, some alterations. And I think here is what it would be a good point for me to step back and just say, first of all, some of the other underlying principles of the vaccination distribution that people can keep in mind is, this is a global pandemic of which none of us have seen. It hasn't occurred at this level in about 100 years. And so it's a novel virus. It's new to all of us. And the situation changes quite rapidly. It's a very dynamic situation. And some days, it almost seems like things change daily. So it's necessarily, it's going to happen that sometimes the plan for the vaccine rollout is going to change. And I can appreciate people's frustrations because, as Terri mentioned, we are all living through this pandemic ourselves, including those of us who are working on the public health response. And there's a great deal of anticipation to, when am I going to be able to get the virus? When is my community going to get the virus? When is, all of these questions. And we try to give the best answers that we can, but at sometimes things change. For example, there was a delay over the last month in both the distribution and allocation to Canada in general and the provinces of both the Pfizer and Moderna vaccines, which had a lot of implications for our vaccine rollout to BC First Nations. So one of the things that's important to recognize as well is, at FNHA and at other First Nations tables, at the regional level, the health authority level, the provincial level, people have been very strongly advocating for First Nations people and Indigenous people in the province to be considered one of the priority groups. There's a whole number of reasons why we advocated for that, partly because of our elders who are valuable cultural resources for us in terms of language, knowledge, ceremonies, and we want to ensure that as many elders as possible are protected by the vaccine. And given we have already, we acknowledge that we have had losses of some elders in communities. And the other reason is, the other couple of reasons just quickly is, we have, we know of evidence, for example, of BC First Nations in this case, who suffer higher rates of chronic diseases, and yet at the same time have poor access to health services. And many communities are rural, remote, isolated. And so just, without that virtual Doctor of the Day program that was stood up during the pandemic, may not have had timely access to services. And I know from, working in the response for the last year, when communities have even a couple of cases, it really raises the anxiety level. And of course it would, because people are worried about it spreading further and having a cluster or an outbreak, and then have very little access to, acute care. So this is the plan as in general, and we have already more or less in British Columbia passed through phase 1. And these are the first 2 phases will cover the higher risk populations. So the first phase one was people living in long-term care, our seniors provincially, and assisted living, including resident staff, and one individual for each person who would be considered an essential visitor. And hospital workers who provide acute care to COVID-19 patients. So these would be physicians working in ICUs, internal medicine, inpatient units, emergency departments, and remote and isolated First Nations communities. And so for the most part, that has proceeded on relatively on schedule. Phase two is it has been worked on, but there have been some delays, as I mentioned, because of the delay in the vaccines actually being shipped to Canada and to British Columbia. So we are still working on some of the populations identified in phase two, while at the same time getting larger shipments of the vaccine so that we can proceed into phase three in a relatively short period of time. So I won't go through this in detail. I will ask to go to the next slide. So as far as the COVID-19 rollout in British Columbia for First Nations, as I mentioned, the most remote and isolated communities were identified in phase one, and the first doses actually arrived in December, around the end of December. And you'll see from the pictures here, just examples of the vaccine arriving. You can imagine the logistics involved in shipping the vaccine to different places by float plane in some cases. In the first month or so, one of our senior executives who actually works in logistics was actually driving packages of the vaccine from community to community and got a speeding ticket, if you can believe it. You'd think the police officer would have, said, "Oh, you've got vaccines, let me help you by, leading you the way," but instead he gave him the ticket. But so it's started to roll out over the last 6 weeks or so. And one of the things, again, that we have always been strongly advocating for at FNHA is what we call a whole of community approach. So this means instead of just as the province in some ways has taken the approach of, we're going to start vaccinating 80 years and older, and then 75 years to 79 years. We have tried to, for BC First Nations communities, advocate in the most part for the whole community to be covered. So in the case of Pfizer, that might mean 16 and older. In the case of Moderna, 18 and older. There has also been some advocacy that takes place when there have been large clusters or outbreaks in communities. So some of the regional health authorities have given vaccines that we can use to respond to outbreaks. An example of that has been the two relatively large outbreaks on Vancouver Island with the Sanéma community and Cowichan tribes. So as of and I should say that, again, because of the limited supply, in some cases, we have had to make difficult choices and not be able to vaccinate the whole community. But we have been forced by the limited supply to say, start with 65 and older in a certain community, and then make plans to go back and give the rest of the eligible community members and who wants to have the vaccine at a later date. So almost, I think around 19,000 doses of vaccine have been delivered. The large majority of that are first doses, a smaller number second doses. Moderna has just arrived back in British Columbia, so most of that allocation over the next weeks, 2 or 3 weeks, I think is going to go for second doses to make sure that the vaccination has been complete. We have about 80 communities that have received their dose 1. 21 are in that partial situation in terms of being partially complete, having their dose 2, and 8 communities are still have just received their first dose. So again, as I mentioned, the plans have needed to be nimble, responding to challenges, etc. The next slide. And I will try to speed it up. I'm happy to share these slides in a PDF form too, if people want. So I won't go through all the bullet points in general, but to say that, again, this type of vaccine rollout provincially for First Nations and Indigenous populations is a massive undertaking. And it would not be possible without engaging with the communities themselves, the regional FNHA teams, the regional health authorities, provincial health authorities, and in some case sharing information and best practices with federal government. So there's a lot of communication going back and forth. And for communities especially, there has been resources developed to help support, both in terms of just general preparedness for communicable diseases, but how to prepare for a vaccine clinic, for example. And Terri has already mentioned the virtual services that have been stood up during the pandemic to provide services. One of the things I saw in the chat that I'll just touch on briefly before I switch to the next slide is the difference between the Pfizer and the Moderna vaccines. And Terri spoke to the fact that these are mRNA vaccines, which use that sort of little recipe of mRNA to teach your cells how to recognize, teach your own cells how to recognize that spike protein and mount an immune response against it. Initially, Pfizer was saying, and most people have heard on the news, that it needed to be kept at ultra cold temperatures, like frozen at ultra cold temperatures, like -80 or something like that. And so what ended up happening initially when the vaccine distribution plans were being made was, because of that necessity of keeping it at that super cold temperature, it could only be shipped and kept in certain places that had the proper freezers equipment to hold it there. And then that limited sort of how far away you could actually transport the vaccine and thaw it and administer it. Lately, I think it's been the last week or so, and Terri, you can correct me if I'm wrong, Pfizer has actually said that essentially it does not need to be treated in that ultra cold fashion, so that it can be frozen at the regular temperature and transported. There's still limitations on the amount of time you can thaw something and before you can administer, and an open vial needs to be used. So now the difference, I guess, logistically is that we could probably now use it in more places than we could looking back at late January, where we were mainly confined to having Pfizer be stored in larger urban centers and only servicing the communities that were accessible within that sort of geography. Next slide. And I'm almost finished the slides, and I see there's lots of questions. So what I would really encourage, people to do is to go to our FNHA.ca website and go to the COVID-19 portal. There's so many resources available there. It can be a little overwhelming, but two specific resources, and one that we continually update, is FAQ section called "What You Need to Know About the COVID-19 Vaccine." And even as recently as a couple of days ago, we added in a couple of new questions that people have. And I think I saw one in the chat. So if we go through those questions later, then it'll remind me to try to help answer that question. And the other one is for a toolkit for communities who are preparing to receive the COVID-19 vaccine. And here I'll just make a note that, one of the big differences between, just flying into communities, giving the vaccine and leaving is, the whole issue of cultural safety. There's, people have strong feelings about vaccines in general in some cases. And as Indigenous and First Nations people, we definitely have a history with past pandemics, with past courses of infectious disease. The racism that we experience in the healthcare system, etc. So the communities themselves have done an amazing job when they've been organizing their vaccination clinics to embed the rollout of vaccines in ceremony. And we've seen incredible pictures and videos get sent back to us of the vaccine arriving in community, being greeted with song and drumming and prayer and ceremony. And the clinic starting, not starting before a ceremony is held, and then thanking everybody at the end of the day. That's quite different, right, than what you might picture sort of in a just general kind of large urban setting. And so that is really important. And as Terri mentioned in her personal story, that she herself, did these some traditional ceremonial things to sort of make it seem right or okay to have had the vaccine and want it to work as best as possible. So some of those pictures and videos are available as well on our website. They're quite moving when you think about it and when you see them. Some videos of our elders getting vaccines. And one of the first ones I think was an elder, a woman from, I think it was, again, I can't remember the community, but she was 94, I think, and she, sat there and gave a video after getting her vaccine and kind of shook her finger and said, you all need to get this vaccine and protect yourselves in the communities. And so, it's really nice to see that people have been quite accepting of the vaccine, because as we said, this is one of the tools we have to fight this pandemic and what will get us out of these public health measures that we're living under. I think there's only a few more slides. Next slide. The one reason why I wanted to put this slide in, and I don't want to overwhelm everybody with the bullet point, is to acknowledge the role of nurses in the vaccine rollout. I think that's always important to acknowledge that, this whole vaccine rollout would not happen without all of the different players. So people with public health expertise, that doesn't just include physicians, it includes nurses, it includes people who have, expertise in project management, who are administrators. Everyone, I can honestly say, has worked so hard on this distribution plan. And in fact, during the entire pandemic, it's hard to imagine what a life was actually like a year ago, because we've all been working differently in some ways. And but I do want to acknowledge the nurses, because in general, they're the ones who are distributing the vaccines and giving the vaccines to people. Physicians are participating in some cases, but nurses are really doing a lot of the heavy lifting. And the other tool that we have in place that's still ongoing and that we're building up capacity in communities is community-based testing. So that's just the other reason why this slide was here. And then I think I'm on to my last slide. If you can advance it. Yeah. So one other thing that I'll talk about just before I end and open up for questions is FNHA has been working to build vaccine confidence. For all of the reasons that I have talked about before, the historical reasons and some more contemporary reasons, and what Dr. Terri has talked about, sort of people having all kinds of questions and sort of second thoughts about the vaccine and what's some of the disinformation, misinformation that's available on social media. We thought it was really helpful to frame it in a positive way, and instead of talking about vaccine hesitancy, talk about building vaccine confidence. And as Dr. Terri mentioned, the regulation of these vaccines only happens when a vaccine is determined to be safe, effective, and of high quality, manufactured of high quality. So there's those insurances in place. But we started this campaign called Be a COVID-19 Vax Champ, and you can go to this part of our website and I think on our social media pages and put your picture up if you've had the vaccine and tell your story, or if you're still waiting for a vaccine, just you can share your thoughts about when you might get it, etc. So these are some of our Indigenous physician medical officers at FNHA. Terri has been fully vaccinated, and I think Dr. Louie in the top right has as well, because they are frontline workers and seeing patients. Dr. Shannon McDonald, who's FNHA's acting chief medical officer, and myself are still waiting for our vaccines. But we can assure you that when our time comes to have the vaccine, that we'll be eagerly rolling up our sleeves and willing to have that. So I think I'll stop there and turn to some of the questions. Thanks.
Awesome. Thank you both very much for that. I really appreciate it. Just wanted to highlight a comment that came in from Riley, saying we are VIPs, vaccinated Indigenous people. That's a fantastic acronym. Thanks, Riley. I appreciate that. So I just wanted to update everybody because we've had a few questions. All of the websites and the resources that were mentioned here will be posted on the website, and you'll get an email for them. So there's no need to kind of try to frantically write anything down. It'll all be provided for you after the fact as well. So transitioning over to questions, I'm just going to throw them out generally, and whichever one of you feels comfortable can just kind of jump in. We'll have a casual conversation about it. So the first question is one of a more, emotional nature, which is, how can I prepare my mom who has Alzheimer's and is a residential school survivor? And I think that that's a really important question to talk about. How can we prepare and support our elders and our family members to go through the process and to trust the vaccine and to engage in that, given some of them may have, really long-term traumatic histories, right?
Yeah, I can jump in. So, I think in particular, when we talk about, the history around, even in medicine, where, there were medical experiments done, where, colonial institutions have caused a lot of trauma and negative health effects that, in a lot of ways we're still experiencing, we're still living through. There isn't a lot of inherent trust in some of these institutions, and sometimes in Western or colonial medicine as well. And so I think acknowledging that that history is real, and that that lack of trust is very understandable, is an important part of this. And so I think one of the ways that we can, so I think one of the ways is just acknowledging that, and then also looking at what some of our Indigenous organizations are doing across the country and in BC, including FNHA. And I think part of having First Nations people, Indigenous people in the early stages of vaccine rollout in priority 1 and priority 2, has kind of raised some of that concern around, well, why are we being chosen first? And I think looking at the fact that COVID has had and is projected to have a worse impact on Indigenous people because of the legacy of colonization and colonialism, is the reason. And it's been advocated for in Canada that because COVID can affect Indigenous people disproportionately, that we should be vaccinated earlier. And that has been something that's been advocated for by our our leadership, like people like Nel and Shannon McDonald with FNHA, and other physician leadership. And it's not always, and it hasn't always, or Indigenous people haven't been given priority everywhere. And so I think it's actually a good thing, so that we can, help to save our elders and save more of our community members, from the COVID vaccine. And so I think changing the lens on it, and that, Indigenous people aren't being experimented on. It's already, it's done the necessary pre-clinical trials. It's been vetted through Health Canada, and Indigenous people are seen as priority, which which is just a different lens to look at it. And, you know, I think for, again, for me personally, you know, I want to, like, I wanted to get the vaccine so that I can continue to provide good care for my patients, and that, you know, and as a role model that, you know, these vaccines are safe, and that, you know, all the literature I've seen has, you know, has supported the fact that these vaccines are very safe and effective. And whereas we know and we've seen the devastation that COVID has caused, you know, at this point, it's now even impacted some of my extended family, you know, a cousin and an auntie who have passed away. And, you know, I think many of us are starting to feel it hit closer and closer to home. And as Nel had said, these vaccines are a bit of a lifeline for that. And I think for people with Alzheimer's, you know, it can be very challenging in particular, you know, depending on, you know, their level of awareness and understanding. And so I think, you know, as much as possible, trying to help them through that and help them through understanding. And you know, also being supportive and getting the vaccine as well can be really helpful.
Right. Okay. Awesome. Thank you. And I'm sorry to hear the impacts you've been experiencing, Dr. Aldred, and I appreciate you sharing it with us here today. Dr. Wieman, did you have anything you wanted to add to that?
I'm just trying, one of the things I think in the other questions, I hope that we touch on a little bit is the urban population. That was one of the things I was thinking of, because as Terri mentioned, you know, this has come up quite a bit in social media posts. For example, Dr. Evan Adams, who previously was our chief medical officer and has gone to work for the federal government, I follow him on Facebook, as do about 10,000 other people. He has many Facebook friends. And so I kind of, I can't remember what that word is called. I creep his Facebook page, and he posts a lot about the vaccines, especially distribution in First Nations communities, because he has that national lens now. And I kind of glance through some of the comments, and, you know, one of the most common comments is people, I think, being a little dismissive around, oh, you know, well, we're just being used as guinea pigs, referring to First Nations and Indigenous people. And I find that, first of all, I find that, you know, that's probably just a symptom of what people's distress is and how they're feeling. I try to be compassionate, but, you know, I have to say, you know, all of us who are working very hard on that, it gets a little tiny bit frustrating, because, you know, in fact, the reason why we are included in the priority groups is because we, you know, people have advocated, not just myself, many other people have advocated, because of all the reasons Dr. Terri mentioned, for us to be in those priority groups, and including with the urban, away from home, off reserve populations, where they will be starting, you know, at the older age groups. For the general BC population of 80 and older, we will be starting at 65 and older. And that makes sense in certain ways, because of the, you know, sort of the ravages of chronic medical conditions, that when we're asked to come up with, you know, the numbers of individuals who are 80 and older, the reality is we don't have that many people who are 80 and older, because people die younger because of the burden of chronic disease. So I just wanted to, you know, really sort of make that point that, you know, we are not being medically experimented on with this vaccine, that we are, in fact, finally being recognized as, you know, sort of a vulnerable population, and bearing the disproportionate load in some ways of the COVID-19 pandemic. And so this is an attempt at equity.
Yeah, absolutely. Thank you, Dr. Wieman. I appreciate that. And I do think that it's important to recognize the efforts of everybody that has been doing all the advocacy and doing all of this work behind the scenes. We talked about nurses and you know, frontline workers like yourself, Dr. Aldred, and, you know, and the wonderful champions we have, you know, working through the public health policies like yourself, Dr. Wieman. So absolutely are. I feel like I speak for all of us when I say our hands go up to you, and yeah, so thanks very much for bringing that piece up. And I wanted to transition while it's kind of on topic, and clarify. So are off-reserve First Nation elders over 65 able to get vaccine in phase 2, or is it just strictly on reserve?
Well, as I mentioned, there have been some recent changes, even just the past 3 days. So because of the delays in the vaccine supply, there's kind of been an intermingling of phase 2 and phase 3. So it's not as definitive as it appears in that diagram. In some cases, if we put a strict age range on First Nations groups or Indigenous groups, and say 65-year-old and over and elders, it's not necessarily for the organizers of the rollout to determine who is and who isn't an elder. That comes from the community level. Each community recognizes who an elder is in their community, and that may be someone who's 60 years old. So we have been advocating for 65 years and older of the First Nations or Indigenous populations and elders. So that would potentially include people who are younger, but who are recognized as elders by their communities. And the urban, I'm just looking at a comment right now in the chat. When we're talking about the urban rollout, that would include all 3 major Indigenous groups: First Nations, Off Reserve, Métis, and Inuit.
Fantastic. Thanks very much for that. So now we have a couple kind of questions that are more on the vaccine specifics, and I know that the science is changing all the time, so I thought we could walk through the questions. Those that we can answer, fantastic, and those that that need to be answered with science and time, then we'll do so. The first one being from Linda, referring to a comment that was made earlier about vaccine and their need for really, really low temperatures when kind of storing the vaccine. Is that why Moderna was delivered to the most remote communities, because of the travel temperatures that were thought to be needed at the time? Or is there a different reason why Moderna was used more specifically?
Terry, I don't know if you have some extra information, but initially the decision around Pfizer versus Moderna was partly based on the logistics, like the need for storage, for ultra cold storage. Because Prince George actually had some capacity for ultra cold storage, that's why Pfizer actually got delivered to some of the more remote communities in a way, which sort of intuitively doesn't make sense. But because Prince George had that ultra cold storage, that's why Pfizer was able to get there. And I wasn't sure whether I misinterpreted one of the questions in the chat, but I did see a question around Pfizer versus Moderna and what happens, what has been happening with the rollout is, as we find out what our allocations are based on a number of factors, including geography, we will say, okay, well, we'll have, say, 200 Pfizer doses go over here, or we will have 200 of Moderna go over here. So if you are living in a community on reserve, and individuals don't really have a choice to say, oh, I'll take the Pfizer vaccine versus Moderna. It's kind of, when it comes to a community, you will get what you get. And I don't mean that in a harsh way. It's just the way that it's getting distributed. And same with the urban clinics that will be happening at different facilities. I think a certain vaccine will get transported to a certain facility, and that's the vaccine that you will get. And as Terry said, both of them have high efficacy, so they're highly effective. Even after the first dose.
Yeah, there isn't any significant difference between the efficacy or the safety of either one of them. So it's really just a logistical concern is kind of what I'm hearing in terms of which vaccine you get.
I can, and just to kind of, in addition, like the Moderna and Pfizer, like obviously they were developed by those companies, and there's small differences in what what the vaccine looks like. However, the mechanism, so the mRNA vaccines are the same, so it's the same type of vaccine. And as Nel said, that they're very highly effective. Their clinical trial phases look very similar. The side effects that I mentioned earlier are very similar. And so like the effectiveness between the two on initial rollout looked like 89 to 92% after the first vaccine, and then up to 98% after the second dose. And now, even now, there's some publications that saying like some of them are actually about 93 to 94% effective after the first dose. And so, yeah, so they're very, very similar, and it's and there isn't one that's better than the other. And there's going to likely be a couple more added to what types of vaccines are available that are different type, meaning that they're not necessarily mRNA. But yeah, but are looking like they're quite effective. And I think the biggest thing to keep in mind is that, you know, in a sense of a global pandemic, that's, you know, we haven't had to deal with 100 years, haven't had to deal with such a mass vaccine rollout, and pretty much almost as long. You know, there's going to be supply issues. And so I would just encourage people, rather than trying, you know, I think it's better to get the vaccine that's offered to you rather than waiting or holding out. You know, as I said, like the safety precautions around these vaccines are all being taken no matter which type. And they're all, you know, being vetted through the regular process with Health Canada. And so I would encourage everyone that once you do have the opportunity to get a vaccine, that I would encourage you to get it, as opposed to necessarily, you know, waiting out or feeling like there's a hierarchy of vaccines.
Right. Thank you. Yeah, very well said. Thanks, Dr. Aldred. So we're going to pivot to another question here, and I'm going to go on a little bit of a rant, which is, so the question is, how long does protection from a COVID-19 vaccine last? And I think I want to harken it back to a comment that I believe that you made earlier, Dr. Wieman, about kind of this race that we're in to develop the vaccines and vaccinate a significant amount of the populations before the vaccine, you know, has the chance to spread and mutate and change in a way that makes that vaccine, I believe it's ineffective, or it would be relatively ineffective. So I want to kind of bring up, you know, hearkening to other kind of ongoing and mutating diseases like a seasonal flu, for example. I'm not saying these two diseases are the same in terms of their severity or anything like that. It's not what I'm saying, but rather that, you know, in the flu, we vaccinate every year, right? And so that the previous season's flu vaccine that you had received would be ineffective against the new season of flu. And from what I understand, based on the science here, what we're trying to do is vaccinate enough of the population, both, you know, in North America and then broadly speaking, you know, globally, so that the COVID-19 virus doesn't have as many individuals to infect and opportunities to mutate and change into something that's perhaps more transmissible or perhaps more kind of severe. So to get back at the question, how long will the vaccine last? I imagine it's hard to determine at this point because the disease itself could mutate at any point. But at this point, you know, it's been relatively effective against the variants, correct?
I can take an initial stab at that question, and then Terry, maybe you can help me out. You know, so for what we know, as you mentioned, Cole, we're not sure exactly how long, you know, the immune response that's triggered by receiving the vaccine, how long that will last, like how long the effectiveness of the vaccine, how long it will protect you. You know, we don't think that it's a short period of time, but like some vaccines need to be given, like even if you're traveling internationally and you get a vaccine for yellow fever, for example, that vaccine I think is only, they recommend getting one every 10 years or something like that. So we don't know exactly how long the COVID vaccine effectiveness will last, but it is important, as Dr. Terri mentioned, for, you know, what we're really aiming for in some ways now, provincially, and that includes BC First Nations and Indigenous people, is to get as many people to have that first dose as soon as possible. That's what we're aiming for. When you have had COVID-19 illness yourself, you do have you develop some antibodies and you have some natural immunity following the period of infection. We don't know exactly how long that lasts, but for example, an announcement just came from Northern Health Authority yesterday that is aligned with sort of what people have been talking about most recently, is that people who have had COVID-19 illness and recovered, that they're asking people to not get vaccinated for about 3 months. So because they have that natural immunity, but the combination of your natural immunity plus a first dose will give very significant protection. But the 3-month period, we're kind of asking for that so that more people who have not had the illness can get their first dose. So we're really trying to protect as many people as possible, sort of as we move through this. And so, you've heard in the news different other things being talked about, like extending the period of time between first and second dose, things like that. And it's because, like you mentioned, Cole, this is, COVID-19 illness is a very severe illness in some cases that has proven to be fatal. So we want people, obviously, to be protected against that. And as Dr. Terri also mentioned earlier, when you have the vaccine, once you've had the vaccine, the first dose, for example, it's very important to remember that you're not immediately protected as soon as you get the vaccine. Your body has to go to work and develop that immune response. So probably 10 to 14 days out from the first dose. And then you would follow up, according to the guidelines now, you would follow up at some point and have a second dose. And because, we're waiting for the whole province to get vaccinated, and that includes First Nations and Indigenous people, we will still have to keep all the public health measures in place until that time, as many people in British Columbia are vaccinated as want the vaccine. And so that still means wearing your mask, maintaining that physical distance, washing your hands frequently, not, keeping your social circle very small. And right now we're under a public health order to limit socializing to your immediate household. And that means people that you share a roof with. And if people have been watching during this presentation, I'm a terrible face toucher. That's not something you should be doing either. I'm really bad at that. I need one of those collars around me that will prevent me from doing that. So you will need to keep up those precautions even after you're vaccinated, because I have seen some people talk about, yay, now I'm vaccinated so I can go out and have New Year's Eve. And that's not possible right now.
Mm-hmm. Yeah. Dr. Aldred, did you have anything you wanted to add there?
Well, just to echo now, so don't look at the, Super Bowl south of the border as an example of what should happen after you get vaccinated. The cognizant dissonance was real there. But yeah, I just to agree that, I think it's really important that we, to keep in mind that for vaccinated people, none of the public health measures have changed. So if you travel out of country, you still need to quarantine. You still need to follow regional travel restrictions. All of that sort of thing. The physical distancing, the hand sanitizer, the masks, all of that. Keeping to your household. I think, it's just really important to do. As we get more information, that may change. There's other countries that are, altering things slightly for vaccinated versus non-vaccinated people. But it's more of a time will tell. Some of the preliminary data shows that for people who have been vaccinated, because I know there was I seen a question around, if you've been vaccinated, can you still get sick and transmit? And so, I think the in theory, you could potentially still get COVID in your mouth and could potentially still transmit. And so that's why, you know, the public health measures are still in effect. There is a small amount of data coming out saying that it does seem that people who have been vaccinated are less likely to transmit, but they're unsure if that means, you know, essentially what level that is. And that's very early data. And that, you know, for all vaccines, for whatever reason, there's always a small number of people who just don't respond. So they just don't mount the same immune responses, say most people would. And it's in the realm of around 5%. And for any vaccine, we've never been able to predict with any reliability who will be a non-responder versus a responder. And so, yeah, so there is people who could still contract and get COVID even after having the vaccine. The data shows that even if that were to happen, that you don't tend to have as a severe infection as those who have not been vaccinated. So yeah, even though that's a possibility, we still strongly encourage people to get the vaccines, because again, there's no way for us to tell. And just because you maybe didn't respond to a previous vaccine doesn't mean that you won't respond to the COVID vaccine. So yeah, so I just wanted to say that.
Yeah, thanks very much. Sorry, Dr. Wieman, do you want to throw something in there?
Yeah, Cole, I was just going to say, I was sitting here listening to Dr. Terri and realizing that we hadn't really answered your actual question, like gotten to the point of it, which is, you know, at some point there has been discussion that, you know, COVID-19 as a virus may mutate to the point where it sort of becomes what we call endemic, meaning it's kind of there, that we will never completely eradicate it. And it may be that, you know, that we go every fall and get our COVID-19 vaccine and we get our flu vaccine. It's really hard to know at this stage. So there's, you know, there's no definitive answer that will take, that will happen. But, you know, things change all the time. But as Terri said, I think the most important thing is for people to really, you know, make an informed choice about their health. But we encourage as many people, when it is offered to you, to get the vaccine. I did see a quick question in the chat that I think we can cover quite quickly. Is I think it was, is there a way to test if you have had COVID-19 in the past but were unaware of it at the time? Terri, this is probably something you hear a lot of in your practice as well. I've seen this a number of times, including one of the people that I work with at IPAC. She went on a vacation in March last year, February last year, down to San Diego and Baja California, and came home and was really sick for about a week with a respiratory infection, to the point where it was very difficult for her to even walk around, and she was really sick for about 5 days. And that's very unlike her. She's quite an active person. And so she was asking the other day, you know, do you think, I'll never know whether or not that was COVID or not, because she didn't get tested at the time, because it wasn't kind of widely talked about just at that moment in history last year. And so the answer to that question is, it's really, you know, it's really difficult in many cases. If you have had kind of an illness with mainly respiratory systems, is what people are thinking of, in the past year or so, we can't necessarily do that testing for antibodies if it was like a long months ago. So in some cases, people will just have to resign themselves to thinking that, you know, oh, I was really sick at that period of time. And it may or may not have been, I don't think we'll know. I think the take home point there is to whether or not that was COVID-19, we will still encourage you to keep up with the public health measures to protect yourself and your family, because we don't necessarily know there have been cases of repeat infection or transmission.
I think the other thing I wanted to highlight there as well is that given the length of time that we've been in this pandemic, it's totally possible for you to have an immune response for some period of the pandemic, but eventually for that to fade as well. So keeping up with those public health measures and getting vaccinated is really important.
Yeah.
Dr. Aldred, do you have anything you wanted to add?
Yeah, I think just building on what you just said is essentially that, some people may have seen advertisements that certain labs are offering like antibody tests to say like, and you have to pay for it. It's not covered by our provincial MSP plan to see if you already have antibodies to COVID. And the reason why it's not covered is because we really don't know what to make of that information. So we don't know if you have some antibodies, if that means that you're protected. We don't know when you would have got infected or when that's going to wear off. And so it's also one of those things that just because you have antibodies doesn't mean you actually like have a robust immune system or that you've actually had it before. So think about things like the herpes simplex virus, for example. About 60 to 90% of people will have some sort of antibody against one of the herpes viruses. And most of those people will never have had it or and will never have an outbreak of it. And so that's just one example to say that antibody tests can be challenging for a number of different reasons. And so that's why we're not really, recommending them or for anything, because we essentially don't know what that will be, and it can give people a false sense of protection.
Yeah, for sure. I think all these last few questions that we've been able to get at is kind of key in reinforcing, for me at least, why we chose the title of the session we did, and that the vaccine is a tool. It's one of the tools in our toolkit to safeguard the safety and health of ourselves as well as our community and our loved ones, but it is only just one tool. And there's a whole bunch of other things out there. We need to be kind of doing everything that we can to make sure that we all stay happy and healthy. So we have one other question that I think is important to get at, even though I'm not sure that we'll be able to answer it fully, but will the vaccine be effective against other variants? And building off of the conversation or the discussion we had previously, from what I understand, the variants are, so you have the COVID, let's just say COVID-1 is a very simplified example, right? That COVID-19 vaccine will mutate into a bunch of different variants for different regions and different reasons. So depending on the way that the vaccine works, in the way that it targets these, your immune system will target these viruses, let's say, in your body. That will kind of determine whether or not the vaccine is a way to determine whether or not the vaccine will be effective. So I think, from my understanding, we're not sure if it's going to be effective against these variants or other variants to come, because we haven't seen the data to test that and whether or not the virus would mutate. Is that kind of sounding like the right idea, or am I off base there?
So again, it's all early data, but there is for this. I've seen some data around the South African and the UK variants that having the vaccine does confer some protection against those variants. But again, it's very early data, and we're unsure how much of a difference it would be. Regarding like how effective the vaccine is. So the numbers quoted earlier around the, after your second dose, you're 98% effective. We're unsure if that would be lower for the variants, and if so, how much lower. But it still seems like it does confer some protection. But again, it'd be one of those things that as we follow the epidemiological data as it comes out for, we'll be able to make stronger recommendations as we go forward. Nel, do you have some thoughts on that?
I don't have much to add to what you said in terms of kind of the numbers, but Cole, you just reminded me as we're getting to the end of our time, what I was going to say in relation to the vaccine being a tool and us having other tools to combat COVID-19. And that includes, as I I had one in one of my slides on testing and tracing is still another tool that we have. And the reason why I'm raising this is because, you know, there is a lot in some cases stigma about COVID-19. And I know that people, for example, you know, and it's connected to race, anti-Indigenous racism, where we've seen in the news cases where communities have declared clusters of COVID-19 in their communities. And then, you know, in the surrounding areas, stores, for example, or restaurants have denied any community members access because of the outbreak. And so there's a lot of, you know, reluctance in some cases and stigmatization that happens. And so I would encourage people, what we are seeing is, you know, people, for example, who may be reluctant to come forward and be tested, even though they have clearly developed symptoms. And it, you know, your infectious period, for example, is 2 days before you develop symptoms and then 10 days after that. And so when people feel like, oh, you know, I've actually got some of these symptoms, like say, for example, you know, they've lost their sense of smell or taste, they've got some respiratory symptoms, they may have some gastrointestinal symptoms, and then they're like, I'm kind of just going to pretend this isn't happening to me, and I'm gonna carry on and, you know, be with my family or whatever. That is you know, not that helpful in terms of spread, you know, trying to reduce the spread of disease. So even though there is the potential for stigma, I'm encouraging everyone to get tested who develop symptoms. And there's guidance that you can follow. You know, you can call 811, for example, and get guidance if you're symptomatic. The other thing that we've heard a little bit about is contact tracing. So that means, you know, if you are identified as a case, if your lab test comes back positive, public health nurses or community health nurses will ask you, who have you been in close contact with? And that close contact means the two of you have been less than 6 feet of each other for 15 minutes of total time. So in a workday, for example, if we were all together, Terry, Cole, and I were together in the studio, and we've just spent this hour and a half together, say huddled over a desk, we would be close contacts of each other. And we've heard some people saying, you know, well, you know, I don't want to look bad and say that I've actually been visiting with a few people, and I don't want to, you know, look bad because I went to work or whatever. I would just encourage people that you know, honesty is the best policy always. And it's very important for us to both have people tested and contact tracing done so that we can stop the spread before it gets any further. So I hope that helps.
Yeah, thanks, Nel. And just to kind of build on what she's saying, it's kind of like, think about it like a harm reduction component. Like, you know, we know the public health guidelines, and you know, sometimes you may step out of them occasionally, but it's really important to come back to trying to adhere to them as much as possible. And if you had an exposure, or if you are feeling respiratory, like having respiratory symptoms, to remember that, you know, we're thinking about like our family and community good. And so in order to reduce the harm of COVID, it's really important to be honest and to self-isolate and follow the public health guidelines as, you know, as strongly as you can. And I just wanted to take like 30 seconds, I know we're wrapping up, to answer some of the questions that came in, or just to reiterate, and that is that, so the current recommendation is that if you've had COVID, you can still get the vaccine, but we're asking people to wait 3 months, or at least that's been the direction from some health authorities, to wait at least 3 months so that we can vaccinate more people, because it's felt like they'll have that kind of natural immunity for about 3 months at least. The other thing is just around, you know, once you are vaccinated, you know, there is a theoretical risk that you could still pass on COVID. And although, as I said, there looks like there's some preliminary evidence saying that it's reduced, it's likely not zero. And that's why even if you are vaccinated, you should still follow public health measures. So as a doctor who's going in and providing in-person care, it's really important that, you know, I still use PPE, I still have my mask, I wear gloves. If people are having respiratory symptoms, I gown up and wear, you know, full PPE with face shields. And, you know, I haven't changed, you know, my process since being vaccinated, meaning that I wear scrubs that go in the washing machine as soon as I get home, and I shower and all of that before I greet my family. Yeah, it's really important, like I said, that just because you've been vaccinated, because we don't have enough data to keep following the public health guidelines and to do those things to ensure that we're keeping our loved ones safe.
Thank you. So yeah, we've reached the end of our time. Thank you very much, Dr. Aldred, for quickly addressing those questions. We appreciate it. Thank you both so much for being here with us today. Dr. Wieman, Dr. Aldred, your experience and your wisdom here is invaluable. And thank you all so much that participated and threw in your questions and shared your anxieties and your thoughts with us today. I've really appreciated being a part of this circle. Briefly before we end, we have more sessions coming up this week, a session on decolonizing sport, as well as Indigenous futurisms. And then the following week, we're going to welcome Dr. Aldred back to the circle with Dr. Ho and Dr. Liu to talk to us a little bit more about culturally safe care in acute care settings. So, so that'll be a really great session. We hope to see you there as well. So yeah, if there's anything else that you'd like to leave us with, doctors, feel free, but yeah, that's all we have.
I just want to say thank you to everyone for participating and for your great questions. And thanks to Cole for moderating. That was amazing. And Terry, I raise my hands to you for all the work that you're doing in communities as well. It was a pleasure to be here today. Miigwech.
Sorry. Yes, I just echo Nel's sentiments. Thank you to you, Cole, to UBC Learning Center for inviting us, and everybody for your great participation. And really the hands go up to, you know, you, Dr. Wieman, and everything that the public health physicians are doing right now, because I know you're carrying an enormous load. So thank you so much. And it was an honor to be here. Thank you.
Thanks, everybody. Bye.
Take care.